Audio is muted. Good evening to all. Thank you, Dr. Anjana, for the nice words. I thank Georgie sir for the opportunity to speak in this wonderful forum tonight. So without much delay, I shall move on to the topic. So today's topic, as you know, is renal denervation in refractory hypertension. Now, we know that hypertension has emerged as a global health crisis from becoming a leading cause of disability and death worldwide. And in 2021, it was responsible for about 10.85 million deaths globally as per our World in Data, as per the research done by our World in Data website series. So the Indian scenario, India is not far behind in terms of hypertension. So the prevalence of hypertension is found to be highest in Sikkim, followed by Punjab, Goa, Kerala, Arunachal Pradesh, Telangana, Delhi, Manipur, and Andaman Nicobar Islands and Karnataka. Now, this is a meta-analysis published in 2018, which estimated the prevalence of true resistant hypertension, and it was found that about 10.3% will fall under the true resistant hypertension category. This meta-analysis is based on 91 studies involving 3.2 million patients worldwide. Now, let's see what resistant hypertension is. Resistant hypertension is defined as hypertension that is uncontrolled despite the use of more than 3 antihypertensive medications at optimum doses, including if tolerated, a diuretic. Now, if BP is subsequently controlled with the use of more than or equal to 4 medications, that is termed as controlled resistant hypertension. If BP is uncontrolled despite the use of 5 or more medications, that is what is termed as refractory hypertension. Renal denervation comes into the picture only in cases of resistant or refractory hypertension. Now, before labeling a patient as having resistant hypertension, we need to see if their medications are optimized. We need to take a look at the lifestyle factors, see if the patient is compliant with their medications. If there is an issue of non-compliance, we need to find out the cause of non-compliance. It could be due to pill burden, due to accessibility issues, due to adverse effects, and so on. Now, if we are able to address these issues, BP can be controlled in most cases. Lifestyle modification should be encouraged in all patients. So when we say lifestyle modifications, one is increasing potassium intake, but we know that this is not practical in most of our CKD patients. Other measures like increasing physical activity, avoiding smoking, avoiding alcohol intake, reducing salt intake, etc. should be undertaken. So here on the right hand side, you can see an image as to what the ideal method to measure BP is. And this method was put forward by the International Society of Hypertension. So what is the prevalence of non-adherence in resistant hypertension? So this is a systematic review of various studies published in the Canadian Journal of Kidney Disease. And it shows that the overall pooled prevalence of non-adherence was 37%. And this systematic review involved 42 studies with 71,000 patients. They also found that if you use direct methods of assessment to confirm adherence, like using urine assays or directly observed therapy, the prevalence of hypertension, the prevalence of non-adherence in resistant hypertension is even threefold higher. So non-adherence is something which has to be addressed before we subject the patient for renal denervation. The other thing is secondary hypertension. Attempts should always be made to rule out secondary causes of hypertension, especially in the young hypertensive patients below the age of 40 and those with new onset hypertension above the age of 60. In fact, the latest AHA guidelines 2025 recommends testing for primary aldosteronism in all hypertensives, unlike the 2017 guideline, which recommended testing only in hypertensives with hypokalemia. So various causes of secondary hypertension are renovascular hypertension, renal parenchymal disease induced hypertension, coaxiation of the aorta, obstructive sleep apnea, pheochromocytoma, primary aldosteronism, Cushing's, thyroid disorders, hyperparathyroidism, to name a few. Now, regarding renal denervation has emerged as an adjunctive therapy for uncontrolled hypertension, mainly for those with resistant hypertension and refractory hypertension, and rarely for those intolerant on drugs and for those with high cardiovascular complications due to increased sympathetic activity, for whom drug treatment alone is insufficient. So what are the modalities we have in place for renal denervation? There are three main modalities for renal denervation. One is radiofrequency ablation. The other is using ultrasound energy, and the third is using ethanol. Now, all of these are aimed at ablating the renal sympathetic nerves, and the radiofrequency ablation spiral system by Medtronic and the ultrasound energy system called the Paradise ultrasound system. These are the two modalities which are approved by FDA. These were approved in 2023. Now, regarding the sympathetic nervous system, the sympathetic nervous system plays a pivotal role in BP regulation by modulating renal hemodynamics, sodium handling, and neurohormonal pathways. The sympathetic efferent fibers innervate the renal vasculature, juxtaglomerular apparatus, the renal tubules, thus influencing renal blood flow, renin release, sodium reabsorption, and increased sympathetic activity is a hallmark of hypertension. So this can result in vasoconstriction, sodium retention, and renin-angiotensin-aldosterone system activation. And chronic sympathetic overactivity leads to an elevation in systemic vascular resistance, leading to elevated blood pressures and end organ damage, highlighting the potential therapeutic relevance of targeting the renal sympathetic nerves. Now let's move on to the history behind sympathectomy and hypertension. So the role of sympathetic system in blood pressure control has been known for a long time now. Animal studies in the past, in the early 1930s, showed that resection of thoracolumbar nerves can control hypertension. Several case reports and case series were published in this regard, but there was about 10 to 20% very early mortality soon after the procedure, and about 70 to 100% mortality was observed after a median period of 4 years post procedure. So this was very high. So there were also other side effects like sweating, impotence, paralysis, etc. And then later on, what happened was we got more effective pharmacotherapy for hypertension, and hence further research on renal denervation was never undertaken. Things changed actually when this case report was published in NEGM in 2009, where renal denervation was done for a case of uncontrolled hypertension. Now, if you see this chart, you can appreciate a remarkable reduction in systolic and diastolic blood pressure after about 30 days post bilateral renal denervation. A reduction in sympathetic activity was also demonstrated after renal denervation by measuring the norepinephrine spillover, showing the role of sympathetic efferents. So this was based on a case report which was published in NEGM, and the patient was a 59-year-old male with refractory hypertension on 7 drugs. So for this patient, they exhausted everything and hence they attempted renal denervation. So this same group quickly followed up with 2 large prospective trials called the Simplicity 1 and the Simplicity 2. Both these trials showed a 20 to 30 mm fall in systolic BP, and the reduction was even greater with time, which means that there was more reduction at 3 months and 6 months than at 1 month. So things were looking very good until the Simplicity 3 came. So this was a large first sham controlled study which found that reductions of blood pressures were similar in both the renal denervation group and in the sham control group, which meant that there was no benefit in renal denervation. Surprisingly, even after 6 months, these patients in Simplicity Hypertension 3 trial did not show any difference between the renal denervation group and the sham group, unlike what was seen in the Simplicity 1 and 2 trials. So this sort of marked the end of renal denervation. So 2 years later, in 2016, a study was published by Howard et al. And what they found was, they tried to analyze the reason for the wide difference in the results between Simplicity 1, 2 and the Simplicity 3 trials. So they found certain issues in the study design, like asymmetrical data handling due to information bias, a motivation towards better adherence to antihypertensive drugs in the renal denervation group to be the main driver for a positive result of Simplicity 1 and 2 trials. They also conducted a post-hoc analysis of Simplicity Hypertension 3 trial, and they found there was significant heterogeneity in BP reduction across various trial sites. So what they postulated was that centers with higher procedural volume and better adherence showed greater BP reductions, suggesting that operator skill and experience could have influenced the effectiveness of treatment. They also postulated that probably in Simplicity 3, the denervation done might not have been completely successful because proper denervation might not have been done. So hence what happened was the researchers were back to square one. So then they went back to the animal studies like they did in the initial period. And these studies were conducted to refine denervation techniques. They studied 3D reconstructed images of animal kidney and tried to understand how effectively renal denervation can be done to have the desired effects. And they made some remarkable findings. So in the early periods of renal denervation, the practice was just to denervate around the ostium and the proximal vessels and the mid vessels and to stay away from the bifurcation. They now understood that the renal nerves do not necessarily wind around the artery from its origin. They can come from quite a distant portion of the aorta. And in about 63% kidneys, renal nerves join the artery even beyond the bifurcation and not just near the ostium. So they concluded that to get effective denervation, it's necessary to engage with the area around the bifurcation and in the proximal branches. Also, at the beginning, they weren't sure about what to do about the accessory arteries. So it was found that by cadaveric studies, they found that about 1 in 3 humans will have accessory renal arteries. And by leaving them out, you can risk incomplete denervation and therefore an incomplete blood pressure response. So a better understanding was obtained from cadaveric and animal studies. So changes were not only made to the procedure, they also made changes to the trial designs. So from then on, they decided that all trials will be sham controlled, and to monitor the outcome, that is the blood pressure outcome, they decided to use 24-hour ambulatory blood pressure monitoring. Improvements were also made in the catheter design to make sure adequate ablation was obtained this time, unlike the postulation they made in the Simplicity 3, where they could not do an adequate ablation. So to reduce variance, patients were on no medications were placed in something called off trials, and those who were on medications were placed on trials. Adherence was objectively assessed this time using urine assays or direct observed therapy. So this is regarding the trial designs that they modeled. So this model of study was developed after the Simplicity 3. Like I said, they designed off trials. So off-med trials. In off-med trials, what they do was they never use any medications. This was basically designed to look at the proof of principle of denervation therapy independent of pharmacotherapy, meaning they wanted to prove that denervation therapy was effective even without medications. This is not what we do practically. That is one thing we should remember. We never advocate renal denervation as a first-line therapy. So this is just for the need for trials, just for the sake of trials. And the other model was called on-med trials. These were designed to see the effect of medications on top of renal denervation therapy. And finally, there was also real-world data collection. So here we can see a schematic diagram showing the timeline of renal denervation trials over the past 10 years or so. So the blue ones are the ones using radiofrequency modality, and the purple ones are the ones using ultrasound ablation. The yellow ones used ethanol ablation. So I will not be discussing all these trials. I will be just focusing on a few major ones. One major trial is called spiral hypertension off-med trial. So this was modeled to be an off-med trial. So what they wanted to prove here was a proof of concept trial. They wanted to establish that renal denervation is effective. So what they did was, this was multicentric randomized sham controlled trial, and it included around 331 patients with a 24-hour ambulatory BP between 140 and 170. And these patients were off antihypertensives for at least 3 weeks, and they were followed up for 3 months post-procedure. So this time they made a few key differences when compared to the earlier Simplicity 3 trial. Like they made sure that they were not just treating the main renal artery, but also the accessory branches where there was a good concentration of sympathetic nerves. And they used an improved ablation device. Patients were also tested for drugs to ensure that the participants remained off medications throughout the study period. So this trial, what they found was this off-med trial achieved a significant reduction in BP control in the renal denervation arm. So one key point to be mentioned in this trial was there was an escape criteria, which meant that if these patients are supposed to be off medication for 3 months, so this escape criteria was necessary. So what they meant by the escape criteria was, if at all at any point blood pressure rose by more than 180 during the 3-month period, these patients are allowed to restart the antihypertensive medications. And it was found that escape patients were more in the sham group than in the renal denervation group. So this study thus provided biological proof of principle that radiofrequency-based renal denervation significantly lowered BP in patients without the confounding effects of antihypertensive medications. Now, the next trial is an on-med trial, which is called spiral hypertension on-med trial. So unlike the spiral off trial, the spiral on trial allowed patients to be on their medications, but up to 3 medications were allowed, not more than that. So to avoid the issue of adherence failure, key aspects adopted in this trial was assessment of blood pressure medications, assessment of blood pressure as measured by ambulatory BP measurement after direct observed let me come once again. So to avoid the issue of adherence failure, what they did was they conducted urine studies to make sure that that adherence was observed, and they used ambulatory blood pressure monitoring to measure the outcomes of this trial. So overall, there was a clear demonstration of the efficacy of renal denervation in lowering blood pressure compared to the sham procedure on the background of up to 3 antihypertensive drugs. No safety signals were observed in this study, meaning this study was also a positive study, just like the spiral hypertension off-med trial. Then there's another trial called Radiance Hypertension Solo trial. So this was a multi-center randomized sham-controlled trial, just like the other trials. This was also an off-med trial design, but the difference here in this trial is that they used the ultrasound denervation system called the Paradise system. Unlike in the previous 2 trials where they used the radiofrequency ablation method. So here too, they found that blood pressure decreased significantly and with no safety signals at around 2 months. When you look at the safety outcomes of all these trials, there were no major safety signals in any of the trials. Most of these RCTs were of short duration. We actually need longer term data. And now there is a global registry called the Simplicity Registry with data of over 3,000 patients. So far, they have accumulated data for about a period of 4 years, and the results so far look very reassuring. Now, long story short, about 60 to 70% of the patients who get renal denervation will have a reduction in the ambulatory systolic blood pressure of at least 5 mm mercury. More patients reach the target blood pressure compared to the sham group, and they were able to do this using fewer medications. So that's about trials. Now let's see some practical aspects. How will you choose your patient? So to choose our patients, we need to make sure that the patients are more than 18 years of age. They should have an automated office BP of more than or equal to 140/90, despite 3 medications at maximum tolerated dose, meaning there should be resistant hypertension, and this should be confirmed with 24-hour ambulatory blood pressure monitoring. BP should, if they do not have resistant hypertension, then they should have uncontrolled hypertension despite attempting lifestyle modification, or they should be having antihypertensive medications but are intolerant or do not wish to be on additional medications. Priority is given to those patients with higher cardiovascular risk. And these are the patients who will benefit most from blood pressure reduction. How will you prepare them for the procedure? So we will have to do pre-procedural imaging once the clinical criteria are satisfied. Like we need to exclude patients with renal artery stenosis of greater than 50%. Patients with fibromuscular dysplasia should be excluded. polycystic kidney disease, atrophic kidneys, presence of kidney tumors, these patients should be excluded. At least one main renal artery that is less than or equal to 3 mm or greater than or equal to 8 mm in diameter should be excluded. So if you look at all these patients who were in the trial, they always had main renal artery diameter within 3 to 8 mm. And of course, the final confirmation of the vessels occur at the time of the procedure using selective catheter-based renal angiography. Other exclusion criteria like prior renal denervation, confounding medical conditions such as aortic aneurysms, peripheral vascular disease, presence of primary pulmonary hypertension with a mean PA pressures of greater than or equal to 25 at rest, patients who require chronic oxygen support or mechanical ventilation, except those with CPAP for OSA, because that again is a condition where there is sympathetic overdrive. Also, patients with orthostatic hypertension not related to medication change should be excluded. Pregnant patients and breastfeeding patients should be excluded. And also those patients with a GFR of less than or equal to 40 ml per minute should be excluded, meaning we cannot use renal denervation in our CKD patients. Now, although they say the GFR cutoff is 40 because all these large RCTs did not enroll patients below 40. But there are some smaller studies which have demonstrated safety and efficacy with lower kidney function. But we will need more data in order to recruit patients below 40. So this is a suggested working algorithm where we first rule out secondary causes, and then we look at lifestyle modification, medication titration to ensure that the medications have been optimized, ensure that the patient has been properly educated on the importance of hypertension control, and that they are well aware of the risk and benefits so they can make an informed decision along with their caretaker in deciding to undergo renal denervation. We should also ensure that appropriate imaging criteria like the ones I mentioned have been undertaken. And then after the procedure, the patient needs to be followed up by a multidisciplinary team. Now, how do we know these patients are going to respond to renal denervation? Well, there are certain predictors. So the only established predictor is high blood pressure. So patients with higher blood pressure prior to the procedure usually will have good control of their blood pressure after renal denervation. Also, situations in which sympathetic activity may be increased, like obstructive sleep apnea, patients with higher plasma renin activity, increased nocturnal BP, and also in situations where the arterial stiffness is low, like if you see those with greater pulse wave, those with decreased aortic pulse wave velocities, and also people with lesser calcium scores, coronary calcium scores. As these patients are going to be having compliant vessels, so they will respond better to renal denervation. Now, these graphs, so these donut-shaped graphs show us about how the participants of these various trials fared after the renal denervation procedures. So the yellow ones, the orange ones depict those with a BP fall of more than 5 mm reduction after denervation, and the blue ones are the ones who did not respond. So we can see that in these trials, most of them did respond to renal denervation. Now let's see what the guidelines say. So now we have the AHA-ACC 2025 guidelines. So one change which has been brought about in these guidelines is that renal denervation is now promoted by the American Heart Association in those patients with resistant or refractory hypertension and those patients with uncontrolled hypertension who cannot tolerate more drugs. Also, the International Society of Hypertension and European Renal Association have provided a level 2 recommendation in those with resistant hypertension for those with uncontrolled BP not tolerating drugs, provided GFR is above 40. the ERA also encourages a shared decision-making process and recommends that it be done in experienced centers, and they have given a class 1 recommendation for this guideline. Renal denervation may also be done in those with uncontrolled hypertension, like I mentioned in the AHA guideline. But in those patients with uncontrolled hypertension and those patients who do not tolerate more antihypertensives and those who express a preference for renal denervation. The ESC guidelines, the European Society of Cardiology, says that we should never use renal denervation as a first-line therapy and avoid renal denervation in secondary hypertension or in those with the GFR below 40, and they have given it a level of evidence of 3. So next question is, will a patient actually benefit from renal denervation? Well, we get the answer to this when we look at the trials. So if you look at the trials, patients who were included in the trials had combined systolic and diastolic hypertension. They never included anybody with isolated systolic hypertension. Patients were above 18 years and below 80 years. Patients had a GFR of more than 40. Patients who were excluded from these trials were those with isolated systolic hypertension, those with secondary hypertension, those with CKD, meaning those with GFR below 40, and those with history of major cardiovascular events. To conclude, it is necessary that we choose the right patients to have better results. So those patients with secondary hypertension, significant renal artery stenosis, or a GFR less than 40 are all no-goes for this procedure. So if you choose the right patient, the chances of them getting benefited will be higher. Hence, I conclude my talk on renal denervation today. Thank you.